Excellent. Thanks, everyone. Thanks for joining. Today, we're going to be inviting some of our special guests, many of these folks who you may know from previous work, to really continue our discussion around pediatric crisis standards of care. Have a couple preliminary statements and information to share, and then I would like to move on to introduce our guests for today and get to the actual important part of the presentation. For those not familiar with the PPN, we're a network of children's hospitals, national subject matter experts, and many other partners who've come together to close longstanding gaps in pediatric readiness, response, resiliency, and research. Funded through a cooperative agreement from the Federal Department of Health and Human Services, Health Resources and Services Administration, we started with a foundation of 10 major children's hospital hub sites across the nation, and fortunately recently have expanded to 13. We really came together to close gaps in pediatric readiness and preparedness, and really to rapidly advance everyday and disaster readiness across the healthcare spectrum. The PPN network covers a wide range of domains and project areas, from traditional emergency management topics like reunification, surge planning, supply chain disruptions, to everyday issues that we're dealing with now that may be magnified in a disaster event, such as trauma care, burn care, disease outbreaks, and looking at the role of out-of-hospital providers in preparedness and response. Listen, we work closely and in partnership with major pediatric focused partners across the US, such as the 3 Pediatric Disaster Centers of Excellence, to the EMS for Children's program, to the Children's Hospital Association and American Academy of Pediatrics. We have a variety of programs, projects, and products, but also put a lot of effort into expanding the knowledge base within the pediatric disaster science world through supporting things like pilot awards and scholar programs. One of the key foundations of this work is actually ensuring that hub sites and frankly, all children's hospitals really walk the walk in terms of preparedness and readiness. In that way, they can then be the group that elevates pediatric readiness within their catchment areas and their areas of impact. And so to that end, and really beyond the scope of this webinar today, there are many QI collaboratives, assessments, and projects in which we encourage your engagement. If this is your first time being a part of a PPN event, there's much more to find once you start exploring what's been built. And in particular, for those if you're from a children's hospital and you're not aware of, not availed yourself of the groundbreaking survey and assessment that's underway, I encourage you to go to our website and look up the Pediatric Disaster Preparedness Self-Assessment for Children's Hospitals. This assessment is a key initiative to measure pediatric hospital readiness. And furthermore, once you peruse the website, you'll see there are a number of other resources available across our digital properties, including courses, continuing education offerings, and a variety of toolkits and materials to continue this work forward. As we turn our head and our thoughts toward what we're going to be talking about today, most of us who've worked in this field for a number of years realize a lot of our work in the emergency management space is really related to contingency. If you recall the foundational work by the Institute of Medicine and others using the conventional contingency crisis continuum, what we are unfortunately starting to see is that often now contingency care is becoming the new conventional care, frankly, from shortages of staff and critical supplies to a 20% loss of pediatric beds in the past decade in community hospitals. The system is strained and a scarce resource on a good day. So, as we explore this topic of pediatric crisis standards of care today, please consider, have you and your team, have you maximized your contingency and response planning? Things like load leveling, surge management, partnership with out of hospital providers. Because although this is critically important information, my opinion is that our collective goal is to avoid crisis standards of care if at all possible. But if that is the direction that a response is headed, that we as a healthcare community need to walk to that line together. There should never be a situation where one hospital is going belly up or going underwater when there's capacity and capability available within the service area. So, Damien, if you could pull up the agenda slide if it's not already up, I'd like to do a quick introduction of our speakers for today. First, we're going to enjoy a presentation from Marie Lozon. She serves as clinical emerita professor of emergency management and pediatrics at in Michigan. She led the division of pediatric emergency medicine for many years, and then taking on institutional leadership roles across the institution until elected chief of staff, serving until her retirement in 2024. She was deeply engaged in the health system's efforts to be prepared for disasters and served as associate chief of emergency management until her retirement. And she continues to engage in a variety of endeavors to improve disaster readiness for children, both at the local, regional, and national levels. After Marie speaks, we'll have Naomi Leventhal. And Naomi is a clinical professor and associate chair for faculty development at the Department of Pediatrics at She's the director of Neonatal Ethics Lab and a clinical ethicist, caring for critically ill neonates in the newborn intensive care unit at CS Mott Children's. And many of her research efforts, and one of the big reasons that we're so happy she's joined us, is to really explore this issue of ethics and bioethics and clinical research ethics as applied to these disaster and catastrophic type events. And then finally, James Hodge, with the Peter Kiewit Foundation Professor of Law and Director of the Center for Public Health Law and Policy at the Sandra Day O'Connor College of Law at Arizona State University. He supports both our work and, frankly, across the nation and world with issues of health law, public health law, ethics, and human rights, having published more than 300 articles and 2 books and many, many chapters. So really a great group. We're so pleased that you all are able to join us and very much look forward to the presentations today. If you want to advance one slide, Damien, a little bit of introductory material. As an FYI, this webinar is being recorded. As each of our presenters get through their sections, be thinking of questions that you would like to ask. We prefer that you use the QA feature that's provided on this platform. After the presentations, we will have time for a brief Q&A session, and attendees can also view and upvote questions as we elevate them to the top for discussion, given our limited time. Next slide. And for those interested in accessing continuing education, it is available for you with through partnership with Children's National Hospital. We will present a more detailed slide at the end, including specific login and code information that you will need to access any continuing education credits for participation in this event. So without any additional delay, I would like to turn the time over to Dr. Marie Lozon, and thank you all so much for joining.
Thank you, Kevin. And I am so pleased to be here. I have worked with everyone on this crew for a very long time, and I'm so appreciative of you joining us today. And I would love to have us, by the end, a great wish would be to have a very coherent, templated, easy to enact set of crisis standards should we ever have to get there for children. But I'm going to be honest with you, this is going to be a journey where there are many more questions than answers, but we have discussions and resources to help us understand the problem better. And my question is always, what if there are more sick children than resources? Next slide, please. And I am an operational, I'm retired now, but a clinical physician and worked in operations for most of my career. And I'd love to thank the operational leaders of the Pediatric Pandemic Network and my co-presenters. I'd like to especially thank Kevin and Damian Seawick, our project manager, for the great job putting this all together. Next slide, please. I want to reflect on our previous discussion. I've put a link, and these slides will be available to you. I put a link to the previous discussion, a hyperlink there. Last September 2024, we presented a discussion focused on the legal and ethical underpinnings of crisis standards of care in a disaster or pandemic. We're going to take that further today and look very deeply at pediatric ethics and the legal landscape. But my introductory remarks for that September 2024 session, and I thank Dr. Deb DeBruin from the University of Minnesota for having joined us as an academic ethicist for that session. You'll see her in that link. My introductory remarks really emphasize that pediatric expertise is already a scarce resource. It's concentrated in our academic medical centers and community hospitals that offer pediatric service lines. And I showed health services research. I showed data that shows that over the last 15 or so years, we've lost pediatric staff beds in the United States for complex reasons, mostly the inability to afford that service line for many community or rural hospitals, along with all the other community needs. But so that's those expert skills have accumulated in the academic medical centers or those hospitals that offer those service lines. But during COVID, this reduction in capability really accelerated. And our rural and critical access hospitals are compelled often to transport pediatric patients who need care beyond their capabilities. So I just wanted to ground us in that, in those basic understanding that we've lost pediatric beds. Those of us who work in pediatrics are very well aware, and that we are very well aware that our brothers and sisters who work at these smaller hospitals must transport. Next slide, please. So here's a pediatric preparedness community's call to action. We lived this during COVID, where pediatric services, specialty care, ambulatory care was difficult because things were shut down. But even worse, there was a stress test of the pediatric care system during the triple-demic. Those of you who don't care for children as a clinical enterprise may not have felt this as strongly, but those of us who do care for children were quite deeply impacted by COVID, influenza, and RSV hitting all at once in late summer, early fall 2022, and lasting into 2023. Pediatric beds, especially critical care beds with children sickening in communities, going to the ER, perhaps getting admitted locally, and the hospital would pick up the phone and call either a children's hospital emergency department or call their hospital colleagues at the academic center or the children's hospital and say, I need an ICU bed, and they would have preferred to transport, and they couldn't find an ICU bed and they couldn't find a transport. It was a fraught situation. So the reality is that we are in a vulnerable state if we should experience a massive surge. And I want to talk about practical operational strategies for your hospital system. Maybe you work with your regional healthcare coalition. I do. I'm the pediatric leader of my regional healthcare coalition. Maybe your state. Hopefully, multi-state partners if you live in a part of the country where maybe your state doesn't have a children's hospital. But you have to talk about these things in advance of a surge. You cannot invent a load leveling system or cannot invent a process in the middle of the emergency. Well, you may have to do that, but it is much easier if you've created relationships ahead of time. Next slide, please. I'm going to show one wonky data slide to sort of reinforce what I discussed last autumn. What I discussed last autumn was that loss of pediatric beds, and there's another way to slice it, and I don't want you to get too into the weeds on this very colorful, very busy slide, except that our colleagues at Lurie Children's Hospital, which is a PPN hub hospital, did this study. It was a cross-sectional study of just over 1,000 hospitals. That's 1/6 of the hospitals in our country. We have a little over 6,000 hospitals, about 4,500 emergency departments in this country. So they did a cross-sectional study in which they studied hospitals from multiple different states, not all states, but they looked at the capabilities of these hospitals by using data of what those hospitals already do, what they actually perform. The bottom line of this study is that 55% of the hospitals in the study were what they would call level 4. In other words, they could perform a CAT scan or maybe a simple laceration repair on a child, but they didn't have the capabilities for doing many of the things that children might need in a community hospital. So they would have to transfer. If you think of it, if you look at the percentages across the top of the graph, the hospitals in their study, the majority were level 3 or level 4 and did not have all those capabilities. This to me is just another emphasis of that pediatric expertise, especially with a critically sick child or injured child, is a scarce resource. Next slide, please. So what is our duty in the preparedness community? It's the duty to plan. That's my first call to you. Strategies to stay in contingency when caring for children. There are going to be needs for surge. There are going to be times when there are too many sick kids for the services we have, but surge plans are key, and they're specifically those that are focused on children. The PPN, this group that we're discussing today, the Pediatric Disaster Centers of Excellence, ASPR Tracy, which is ASPR's technical resource website, and which is a great fount of many good resources. And some of our states, and I'm going to highlight my own state of Michigan and my colleagues at the Minnesota Department of Health, have taken a crack, and many states have actually taken a crack at surge plans and even crisis standards of care. So if you are working on an annex for children in your state or at your hospital system where you're not a children's hospital, but take care of some children in your hospital, pediatric surge plans should be something that are in your book of business. Next slide, please. I didn't emphasize it, but on that last slide, and I'll call them out again, our colleagues RAPM, the Western Regional Alliance for Pediatric Emergency Management, have a 2023 surge playbook. And within that playbook, there is a plug and play, a fillable, scalable set of guidances for you to sit down with your organization, whoever you're working with, if you're within a hospital, if you're within a regional healthcare coalition, and say, how could we use some of these resources to surge if we had a huge number of sick or injured kids? Next slide, please. So there are just-in-time resources to train staff and other folks who are not necessarily experts in pediatric care within many of these toolkits. I showed a picture here of the Minnesota Pediatric Surge Toolkit, and they mentioned ways to uplift your staffing, uplift your staff skill and maybe pediatric specific respiratory care, for example. During the triple demic, many of us did many town halls under the auspices of ASPR, either with our regional healthcare coalitions, with our regional disaster response health systems. But we did many open town halls to work with our community providers on how to take care of kids until they could be transferred. And those just-in-time training resources are available on so many of the platforms that we talk about today. Thank you. Next slide, please. And I want to mention specific small projects that could be scaled and would add to your pediatric surge plan. I mentioned a few specific projects and concepts because it depends on your state, your region, and how you would have to surge. Things that, we wouldn't surge in Michigan like we would in Montana or Florida, et cetera. Sometimes children's hospitals are concentrated strongly in a geographic area, and load leveling is easy because they all know each other and they just pick up the phone and take care of it. Other places have scant resources and need to load level or share more broadly across a bigger geographical area. But you have to live in your world, and depending on your state or region, surge strategies could include, and I'll talk about this in the next slide. What about PICU in the MICU? And what about pediatric medical operations coordination cells? I have a little reference there, and I'm going to call out a RAPM colleague, Dr. Mary King, who is an investigator in the RAPM Pediatric Center Disaster or Pediatric Disaster Center of Excellence, who is a critical care physician, and writes about using the medical operations cells in Washington State to really load level between pediatric hospitals during the triple demic. Sadly, I do believe that sometimes these operations can be at funding risk. So not every state has a PMOC. Not every state even has a MOC. But these are very good load leveling resources. If you can develop and read about how to do that, that might be useful for your state. And I want to talk about a kind of a passion project in the state of Michigan. The triple demic really hit home because even though we have 9 centers for children to receive critical care services in the state of Michigan, that's excluding neonatal care, but 9 PICUs, 3 at the quaternary care specialty hospitals, and then 6 additional ones, even though we feel that we're advantaged in that sector, we found that during the triple demic, we ran out of ICU beds at times and had to transfer some kids out of state. This is to us a very concerning type of situation. And we came up with Pediatric Critical Care Safety Net. And this is very much in its infancy and is being explored. And in fact, about a month ago, there was a meeting of medical leaders across our state to look at creating a pediatric critical care safety net, much like a pediatric critical care PMOC, to load level in case there was ever a surge. These are just 3 things that I mentioned. I'll talk about PICU and MICU because that's something PICU and MICU doctors can do in their own hospitals. Next slide, please. PICU and MICU, this is Dr. King's paper. Again, I call out Dr. Mary King of RAPM, published in Chest in 2022. I want to call out that pediatric ICU doctors stepped up during COVID and turned themselves into doctors to adult and elder patients by cross-training and by turning themselves into adult ICUs in Children's Hospital. We did that in my own hospital. The PICU and the MICU concept flips that and says, can we start to load level our PICU patients by utilizing MICU expertise? This is very much what we did in COVID, where we did force multiplication by doing just-in-time training at the elbow support. And you see that this adult intensivist can rely on a pediatric intensivist, a pediatric pharmacist, and nursing. If they choose to care for a child who's of the right age and possibly within the skill set of their unit, to offload that unit so that they can care for the youngest and the sickest in the pediatric ICU. So they use the term critical clinical prioritization. as a stage between contingency and crisis. This is how you could load level. Next slide, please. This isn't going to happen without thinking about things ahead of time. They mention in this paper, understanding your local and regional capabilities. What do you have in your region? How could you load level, even within your hospital? Have you knocked on the door of your medical ICU colleague and said, if we got into trouble in the PICU, and every PICU in our state was jam-packed full and there was a national issue, how could we load level? How could we put maybe teens and older adolescents who are of the right age and size and in your medical ICU? How could we do that? That's not going to happen without planning. Next slide, please. That's just one example. So I do want to prepare you to discuss to me, a very fraught subject by just calling out a quotation from a mentor of mine from the University of Chicago, Dr. John Lantos, a pediatrician who also studies ethics. Decisions about allocating scarce life-saving resources are brutal. He comments that all choices are bad, but some are worse than others. But the doctrine of fairness must be achieved. It's essential for if we ever got to this point. Next slide, please. But I want to call out the work done by my colleagues at Rapham with the assistance of Professor Hodge and some states, including my own, for taking this on and addressing children in their state crisis standards documents. I worked for probably 16 years with the state of Michigan group that worked on our scarce allocation resource document. And I know colleagues such as Dr. Deb DeBruin, who you heard from last September, worked on the crisis standards of care of Minnesota. So some states have definitely taken a crack at this, and the Rapham group published a template to get folks started thinking about how they would approach this. But I do want to give Dr. Chris Newton, who's the principal investigator of the Rapham group and also one of the quartet of lead investigators in the PPN. He gave a talk that is quite recent, actually, on crisis standards with pediatric perspectives. And I was deeply moved by a line in that talk that said, we will never, ever talk about not giving any care. We always have to give some care, even if it's palliative or not expected to result in survival. But we can never talk about withdrawing. We're not going to care for a child. So I just wanted to make sure that many of us that do this work think about how that might go toward the most extreme circumstances. But I do want to call out the ethical need for providing palliative or comfort care. I don't want to belabor that. That's getting too deep in the weeds of how one would provide care. But I do want to say, look at these resources if you want to think about this for your own, your state, your healthcare coalition, your hospital. Next slide, please. That was a little extra bit from the Michigan guidance. Next slide, please. So operational planning to remain in contingency. This is the charge. And a colleague of mine less than a year ago wrote a commentary in JAMA Open about the need for a national plan to sustain critical access to children's hospital services. This is yet another health services research, one of the best in the field. Dr. Matt Davis used to be at U of M, now he's at Northwestern. And he says, we must remember that in the face of mass disaster, kids will still be born prematurely. There'll still be the need for blood transfusions, ECMO, and expert intensive care. And we don't have a national strategy for this. We continue to erode pediatric services, but haven't really talked about how we will fare in the face of an extreme pandemic or disaster where we really are losing pediatric care. Next slide, please. And I want to thank you very much for your attention. While I brought the operational call to action to plan, I want to turn it over to my colleague, Dr. Naomi Loventhal, who's a working neonatologist and just literally came from the unit to speak to us today, and she will discuss the bioethics portion. She's also a working bioethicist at my hospital and has sat at the bedside of many families to discuss the ethics of care. Thank you.
Thanks so much, Marie. It's really an honor to be here. I think the most fun and interesting work I get to do is when I get called outside of my own area of work and to meet other interesting people in other fields like this one. So it's really an honor. And I also, got to work with Marie under her leadership in our own hospital crisis meetings throughout the pandemic, and really got to watch her in action doing this. And that's something that I will never forget, I think, for the rest of my career. Next slide. So everyone learns in medical school or at some point in their training over and over again about autonomy, beneficence, non-maleficence. And then justice is this kind of thing that we learned about, or at least I learned about, is like, and then over here, there's this resource thing that doesn't really happen because we don't really have to dole things out unless you are in the business of allocating organs, right? And we learned about these different ways that you might hand out something scarce, but it didn't really come up in a practical way very often. And so I had not given this a lot of thought, I have to say, into how this might really affect my life until March of 2020. Next slide. And just before I get into what happened when I did have to start thinking about this all day, every day for months, I just want to talk a little bit about, for people who don't live this the way I do, just the contemporary lens of pediatric ethics, if you're doing it. One is that we don't talk about parental autonomy in the way that we talk about our autonomy for ourselves. We've moved to this concept of parental authority, where what parents do when they make decisions for their children is highly important in informed consent and decision making for children, but is fundamentally different than the thing that we do for ourselves when we make healthcare decisions. And how we understand this, how we think about where the limits of parental authority are, how we think about what parents can demand, what they can say yes to, what they can say no to, is constantly changing. And I think it's what makes some of the hardest aspects of what we do. And children exist in families, and many families are complicated for a lot of different reasons. And one of the things that became really apparent to me during the pandemic and since is that some families are really marginal. And when I mean that is in terms of the resources that they have available, the emotional resources they have available, the material resources they have available, and those challenges that they bring to the table when they're making these decisions are not something that you can park to the side. They're part of these decisions. And I think that in the contemporary world of applied bioethics, being aware of that and having that be part of the discussion is just part of the story in a way that it didn't used to be. And as we think about concepts of what it means to be a good parent, of what a good outcome means, and the scope of parental authority, we're not monolithic about this. And although most of what I'm going to talk about next isn't really about that, I wanted to just give a sense of the way we apply bioethics is much more complicated and I think nuanced than sometimes I think our earliest trainees want to think, and the way sort of a newspaper story about this might want us to think. Next slide. In a public health crisis, everything turned upside down, and suddenly we were talking about justice all the time. And I was thinking about this all the time, and this talk for me is very much written, and the title of this could have been what I learned during the COVID-19 pandemic, because then to some extent I went back to not doling out resources as my full-time job. But suddenly we were talking about justice all the time. Next slide. So in our ordinary lives, when we think about resource allocation, we're often thinking about things, certainly in like classic bioethics, about things that are relatively easy to count, that have not a whole lot to do with how big people are, more or less. So when you're thinking about who gets a kidney, I mean, yes, there are size considerations in things like transplant, but generally, they're sort of one-time allocations like whole solid organs. And more and more we are talking about things that are reusable, like an ECMO circuit or like a hospital bed, as being things that we can run out of. Next slide. But I think where this has evolved and certainly continued since the pandemic is things that we are running out of all the time, like blood products or like medications. I mean, there's always something on shortage at my hospital. And one of the things that's interesting as a person who takes care of the smallest patients in the hospital is when you start taking into account of how much someone's going to want, you do start thinking immediately about resource allocation. So one vial of a scarce resource can help several of my patients, but might not even be a complete dose for an adult, right? One unit of blood is multiple transfusions for one of my patients, right, over a course of several days. And so how we think about what we're going to do with a very limited supply of something, we start thinking about things like, about is greatest good for the greatest number the way we want to go? How are we going to think about who deserves this last vial of medication most? Next slide. The modern mess that we're in, and I'm glad that Marie talked about this a bit, is this idea of things that we can run out of that are much more intangible. And I'm a little cheeky when I talk about time, money, and feelings, but I think about this all the time because it's our expertise in terms of how much bandwidth do we have? How much energy can we give to things that are really hard? How much money can we spend, and how much just personal investment can we give to the hardest situations? And I think that this is something that it's impossible to quantify, but this is our lives. This is my life today as I walked away from one bedside of one sick baby to go spend time at the bedside of another one. And I think that we're talking about this more and more in a lot of ways, and it is on some level rationing when we say, I only have so much attention. Next slide. So in a crisis, everything gets turned on its heads in terms of what we have, what we're able to run out of. We talked about blood products all the time during the pandemic. And we talked about things that really just changed, not just how are we going to give one thing to one person, but what are the implications of things like sharing, right? And I don't believe that, I couldn't remember if anyone ever got to 2 patients on one ventilator, but we certainly talked about it all the time. And this is the middle top row here is I couldn't find a real picture of humans of 2 humans on one ventilator. But when you think about what that means, it's probably not the same. 2 people on one ventilator might be really inventive, and it might really sound like a very creative way to solve a problem. But if you're that patient who's getting a half a ventilator, your experience of mechanical ventilation and the safety and efficacy of that is probably different, but we had to make those choices. We accessed healthcare in a completely different way. Our experiences as healthcare providers was completely different. We dealt with, am I safe enough? Is this good enough? I just finished the other day a bottle of Tylenol that my husband ran out and bought in those days as the grocery stores were closing down, when they were telling us that we couldn't take any ibuprofen because it might kill us and that we had to have Tylenol. And you can say that bottle was expired and fine, but I remember this running out of Tylenol experience. And finally, the picture on the bottom right, that's not a COVID picture. That's a picture of in the wake of Hurricane Katrina. That's Memorial Hospital in New Orleans, special to me because I grew up there and my brother was born in that hospital. But thinking about other times that public health crises have really come before us, but thinking about the way we behave in crises and the way eyes are on us in crises, everything gets turned over and gets turned on its head when our world gets turned upside down. Next slide. One of the other things we learned during the pandemic. So this picture I took from my first kind of like home makeshift office during the pandemic. I was up in my upstairs guest bedroom. It was before I'd figured out that I could just put dual monitors in my house. So I had like 2 laptops running a lot of the time. And actually the Spotify playlist that's running on the computer on the right says totally stress-free. I was not totally stress-free, but I was working with the members of the AAP Committee on Bioethics that I was a member of at the time, trying to put out guidance to America's pediatricians on what we were supposed to do. And at the time, the AAP didn't have any mechanism for us to do that under the auspices of an official AAP statement. If you've ever written one of these, they take years to go from sort of conception to publication, if you're lucky 2 or 3. And there was no mechanism that we could find to publish that any faster. And so what we did is, as a committee, we just wrote a paper and wrote to the editorial editor of Pediatrics and said, do you want this? And can you turn it around really fast? And they worked with us. But it was striking to us that as members who were willing to give a lot of our time to the organization, that we just didn't, like, emergency guidance wasn't something that our biggest 67,000 member organization had any mechanism of doing, beyond some of the things like infectious disease guidance and things like that. But the Word document in the background is actually this statement that we were working on when we wrote this, and it's one of it. It was just a very different way to write a paper. Next slide. And a lot of the work that I was doing with colleagues in the beginning of the pandemic was really thinking about who was going to get ventilators, who was going to have access to things. And when a lot of your work stems around children that either are likely to have disabilities or already do, thinking about how society was going to value children who weren't healthy. And I got approached from different groups. I don't work a lot with children with neuromuscular disorders, particularly older ones, but the pediatricians who really care for children with conditions like spinal muscular atrophy, thinking people doling out ventilators might not understand what's available in 2020 to those children and how much that has changed from when they went to medical school. And when you think about what's available to these children, do people even know that? And how will we be able to convey what's possible for these children as they're saying, maybe they go to the end of the line for ventilators? There was also a lot of discussion about people who were already on home ventilators and what happened when they got sick and needed an acute care ventilator in the hospital. Huge amounts of time spent on preemies, and I'll talk more about that in a minute. But really thinking about long-standing understanding that in our society, there are really strong biases against the smallest premature infants, driven largely by not understanding what the outcomes are and thinking about how we were going to advocate for infants with the potential to do really well, even though they were on ventilators for months after birth. And they weren't going to stop being born, although interestingly, eventually they did stop being born. And finally, thinking about, groups like this think about formal strategies to allocate quantifiable resources. But what we got a lot of calls about as a clinical ethics committee during the pandemic was individuals who said, I feel like I should make decisions at the bedside about how I give this FFP, because I know there's not a lot of it. I know we're the hospital's on a platelet shortage and we have standard hospital platelet transfusion thresholds. And I don't feel good about giving this. And trying to get our individual clinicians to not feel this burden to make individual decisions and let us do this collectively. Next slide. So we started seeing these real-time papers come out about bringing back these sort of resource allocation schemes that we learned about. For me, this was a couple of lectures, during med school, during residency, more lectures during my ethics fellowship, thinking about the ethical underpinnings for different resource allocation strategies. And I'm not going to go through them in detail today, but what I want to bring through is that suddenly we had to think through these in a different way and really think through what would it mean to actually apply this. And suddenly things like, I had been really drawn to things like this fair innings argument that you only got, that if you were at the end of your life, maybe you'd had your chance. And as a neonatologist, that kind of checked out until I started thinking about my aging parents, right? Who I was fairly attached to having live a while longer. And we started reading articles from perspectives from people who said hey, I'm not really digging this sort of seemingly harmonious idea of fair innings because I don't really feel like I've had enough. Or these really compelling arguments from people with disabilities who are really worried about how they'd fare. And recall that this was happening during a time of really, really difficult reckoning with America's history with implicit bias and racism and structural racism in our healthcare systems. And we were trying to grapple with that while we were trying to develop these systems. And so I think in some ways, it had to happen. I'm glad that we were forced to contend with the limitations of these systems, which we did really early in the pandemic. But we were suddenly playing this out in a different way and thinking about also things like what's the role of being a healthcare provider and where does that put you in the line? And it had to do with what are you owed from having put your life on the line to work in the RICUs around the country and work in the field hospitals, but also what do we need to do to keep these people alive so they can keep taking care of patients, right? And all of these things had to be played out in a different way. And it turned out it was much harder to operationalize than anybody had ever imagined. Next slide. one of the things that we really had to learn is that sort of the easiest things to apply were in some ways the worst, right? This idea of like first come, first served really didn't work. Like getting through the door first. If you think about all the things that help someone get through the door first and who gets to get through the door first, it's almost never the right idea. Um, and uh, and so that was a really, I think it's so appealing because it's so easy and it works so rarely. Um, Age got really complicated. But things like, what if keeping children safe keeps everybody safe? And one of the things that became clear during the pandemic was kids not having COVID-19 was probably going to be good for everybody, right? And that came to clash with ideas like, generally, we don't test vaccines on children first. So how do we balance the idea that we'd like for children not to have COVID, but we don't test the vaccine on them first? So again, lots of thinking about how are we going to apply these allocation schemes in an appropriate, well thought out, informed way with the right people at the table to meet with people like my friend Marie to help her operationalize this in real time in the command center. And so we met every week and we talked about it every week. Next slide. So I am not necessarily putting forward this complete live system, which was one of the things that was sort of playing out. So what would happen during the pandemic is someone would say we should do it this way, and then there would be 18 articles saying yes we should, no we shouldn't, and everybody had great points. And I'm not putting forward the complete live system as something perfect, and it doesn't do the best by my patients. But what I liked about this paper, and the reason I'm showing this here, is because I think that it brought out that you couldn't just sort of suicide on one ethical principle when trying to think through what is really going to happen, and that you had to probably think about a few different principles and think about how to bring those together in a harmonious way, with some sort of understanding of where is the public right now, and how do we get public buy into this, how do we implement this in an achievable way, and that the more important thing was that it was a multi-principle framework. And again, I still haven't quite wrapped my head around how this would like actually, I'm trying not to say executed when you think about playing out scarce resource allocation, but really just thinking through like, if you're going to do this, you really have to get into it. Name what the principles are. One of the things that I think is helpful in all aspects of applied ethics is naming what the principles are that you're using. And so thinking about prioritizing the worse off, maximizing benefits, justice at the forefront, and also thinking about maximizing lived life years all at the same time was kind of possible. Next slide. All right, but now I'm going to shift gears because one of the things I really wanted to talk about today is the idea that scarce resource allocation was not the only thing that we were doing. And in fact, we were doing a lot of other things also. Especially thinking about what are we owed? What does the health system owe us as the people who are walking out the door and into fire every day? What were we owed? We spent a huge amount of time thinking about things like how are we going to give parents access to their children in the hospital when visitors were not allowed in the hospital. And if I learned anything about just children's hospitals in general, it's that parents visiting their children in the hospital are not visitors, they are parenting their children. It's a different kind of relationship, and that we can't think about it as coming to see your child in the hospital as being a nice to have. We talked about not having access to services and what it meant to be in a high-rise building in Manhattan with a child with autism who didn't have access to services and couldn't even leave the house. And we also talked about what is the best way to test a vaccine during a health crisis, and is it the way should we be doing it the way we normally test vaccines? I had this very interesting lived experience of my own children were in the Moderna trial, and I lived out every single principle of pediatric research ethics watching my own children in this trial as it was happening. So I actually have a whole talk of like pictures of my own children in the trial, like and my own ambivalence about things like assent, as my child was like not that interested in the research blood draw, and my strong interest in him being randomized into potentially getting vaccinated early. Next slide. So this is a slide I pulled directly out of one of my real-time slide decks from that time when we were talking about this all the time. And I certainly talked about crisis standards of care all the time and how crisis of standards of care would apply to children with chronic conditions and disabilities. we were talking about pediatrician redeployment all the time. And what was our role in, as Marie was talking about, like, how could we help when most of the people who were really sick were adults? Neonates in the NICU were not getting COVID. We talked about what our health care institutions owed us. We talked about restrictive hospital visitation policies. We talked about the ramp up. We were always talking about what is the ramp up was going to look like. Everything's closed. What goes first? Which things are we going to do first when we can open again? We talked about school reopening all the time and who ought to get back into school first. And if you're like, you're a doctor, why are you talking about this? And to me, health and education are not really some things that you can separate, especially when you think about how many healthcare services are linked to education in this country. And we talked also a lot about parents rejecting infection control. And we talked about the idea that I had actually blocked this from memory, but there were these sort of like parties that people would have where they would just sort of like reject the whole idea of like germ theory and have these parties to show like we don't believe in any of this isolation. And how are we going to respond to parents who are choosing to expose their kids to sort of unsafe practices around COVID containment? Next slide. Probably have to speed up a little bit. So this is a picture of our about to be stood up field hospital at University of Michigan. I never stood in this building, but Marie's nodding because she did. And we had really intense discussions as a group of neonatologists about our potential role in working in this field hospital, because I'm going to argue that if I can start a peripheral art line in a 23-weeker, I can probably start an IV in an adult. Right. And I can probably handle a convalescing adult who's been the sickest they were going to be in and be in this field hospital. And the conversations we had was, wow, we really feel like we have some obligation to participate in this. But what happens if all the neonatologists get sick? And we can't, there's nobody that can step in for us. And we made the tough decision that we couldn't really put our health on the line and not be available for our neonates. And we didn't volunteer for the field hospital that I think was within one day of opening and didn't. Next slide. Again, we talked a lot about our risk of getting COVID, what it meant to be coming to work, and this sort of experience of like, especially when you're embedded in a large central campus, that the rest of University of Michigan was home and we weren't, and we were working, and this sense of not always feeling like we had everything we needed. Next slide. I already talked about this a little bit, but it made us pick apart things that we thought we understood and didn't. And I had never thought about things like, why do we have policies around who can visit the hospital? Right? And what is the purpose of these conditions? And prior to the pandemic, it didn't have anything to do with things like preserving PPE, right? It didn't have anything, it was just everything around who we do and don't let into the hospital changed, and we were not ready for this. I mean, one of the things we were absolutely not ready to do was think about turning on a dime the entire model of who gets to walk through the doors of the hospital every day. Next slide. I never had to. My work had never really taken me into the understanding of an emergency use authorization and what it really meant. And as someone, my research ethics philosophy is really around that research is good, and that research, our job as research ethicists is to keep it safe so that we promote an enterprise that's fundamentally good. And there was benefit in limiting emergency use authorization to patients who were in trials, to make sure that we were collecting data and not putting out unsafe drugs, but understanding that the minute you limit access to something to clinical trials, you are introducing bias into who has access to it at all. And institutional policies around emergency use authorization and the really complex informed consent discussions you have to have when you're talking about research drugs with patients, especially when they really want that drug. This is a whole other level of informed consent, especially in a public health crisis. Next slide. Access to experimental drugs and vaccines for children is a difficult thing in a public health crisis. The research ethics tension is always access versus protection. How do you get the best treatment as fast as possible to the most people as possible without hurting anyone? And in the case of a experimental vaccine, how do you protect individual child health and public health, public child health at the same time. And there were some really arguments put forth around sort of the risks and benefits of studying children in a vaccine trial earlier or later. And we did end up studying children a lot later than we studied adults. Next slide. We also learned a lot about research ethics and integrity. And I think one of the most important and saddest lessons of the pandemic is what happens when you don't have good science and you let, drugs into arms before you know what you're doing. And when we think about the impact of things like this ill-advised hydroxychloroquine adventure on the pandemic, it wasn't just that it didn't work, and it wasn't just that we weren't getting people the right treatment. It's that people who needed hydroxychloroquine couldn't get it. And the rise and fall of poorly vetted, poorly studied, insufficiently studied medications during the pandemic was like quite brutal. Next slide. And the retractions, the relentless retractions from really good quality prestigious journals was something that we've never seen before. And one of the things we know is that retracted studies keep being cited over and over. That's gotten better, I think, since then. Citation management software and PubMed and things like that have gotten a lot better at like making it really clear that something's been retracted. But the lasting impact of bad science that we saw come out of the pandemic, sometimes well-intended, was real. Next slide. All right, so I'm going to wrap up. I know I'm at time. Just by doing what Marie actually originally asked me to talk about, which was to talk about the experience of being someone not taking care of COVID patients during the pandemic. And so this is me at the end of a shift in the NICU, early in the pandemic after a first responder parade where all the ambulances and fire trucks had gone by the hospital. Next slide. Doing my thing that I always did that had nothing to do with COVID. Next slide. Taking care of conditions like meconium aspiration syndrome and congenital diaphragmatic hernia, for which we need, next slide, ventilators, right? And what struck me the most during the pandemic was the number of people who told me to my face that I didn't have a ventilator problem because we use different ventilators than adults. And this included pediatricians, next slide. But at my hospital, we use the same ventilators for everybody. There was no special pediatric ventilator. Next slide. There was also no special pediatric ECMO, so I couldn't find two pictures of patients on exactly the same ECMO, but that's an adult on ECMO. Next slide. And that's a baby on ECMO. And this is even a situation where size doesn't matter that much because it's the same circuit with the same amount of blood. And suddenly, my patients who needed things that work really, really well for them, needed them when legions of adults needed them for their COVID care. Next slide. And we opened our scarce resource allocation policy and said, you don't talk about neonates in your resource allocation policy. And so I pulled together some of my neonatologist colleagues who weren't bioethicists and said, I need you to help me write this. And we sat and we wrote, keeping in mind the challenges of preemies, and had to think about things like, are we going to put our names on this document? And in what order are we going to put our names on this document? And we had this very intentional conversation about nobody taking priority on whose name was going to be on this document as we put our kind of made decisions about which of our patients were going to get ventilators first. And we found a lot of support for doing this. Next slide. Promise it's my last one. So what I learned the most about the pandemic was being in the room where it happens. The foundational ethical principles still applied, even though the contextual features were really different. But people who knew almost nothing about children didn't seem to balk at making decisions for them. Assumptions about children and well-being really need to be explicitly stated and tested because you don't know what people are thinking. We were not ready to put out guidance quickly, and we should have been. There's this famous adage that good ethics start with good facts, and you don't have to be an ethicist to help you find those good facts. And this idea that, plans are worthless, but planning is everything. Every resource allocation is going to fail someone, and you have to see that in advance. Next slide. Really appreciate the opportunity to be here. Sorry I took up a little too much time. Looking forward to the Q&A. And I'm going to send it over to James to wrap it up.
Okay, Naomi, thank you. So as she noted, listen, Q&A is coming right around the corner. I'm going to wrap up with some observations on the legal landscapes and fronts. I'm going to be very brief and quick, and with Damien's help, moving through our slides, we're going to get you right there to that Q&A portion that Kevin will lead us through. Next slide for us. Thank you. These are the very brief things that we want to discuss. Everything you're seeing on screen is available to you in some format or another. So some of the work that we've done, as Maria and I have with RAPM and other initiatives through the Pediatric Preparedness Network. So the things I'm going to talk about, kids in crisis, the sort of legal issues generally, those core legal issues that we see in crisis standard of care, liability-related concerns that are going to hit us in many different facets. All of these things very neatly laid out for you in advance through RAPM and other specific documents, as Marie mentioned. Next slide. The one thing that's not so neat, and it's not so easy, but of which we can discuss in Q&A and or any other front, are the types of emerging legal questions and issues that are dominating the headlines literally as we speak. These concerns can impact everything that we do today, tomorrow, a year from now, in relation to how we implement legal concerns involving pediatric patients in crisis or otherwise. The sort of administrative agency authorities that you see, the influence and regulation of misinformation, concerns over vaccination recommendations. I mean, that's just ripped off the headlines, as you know. Anti-discrimination measures, extended how we're going to give access to healthcare in the United States, who gets access under what concerns, pursuant to congressional and other activities that we're seeing, race-based limitations and immigration policies and familial reunification. Every single one of these issues could be its own webinar and will dictate and dominate some of what we may see. But let's leave those as they are, as relevant observations that take us through to the next slide. Because the types of issues you're seeing in regards to kids in emergencies, when it's all about kids and everything we can do to actually make sure this population of patients gets the very best care we're talking about, yeah, you've got dominant concerns like with kids in any situation, crisis or conventional. Parental interests are strong, and by parental, I mean any caregiver's interest that has legal authority to make those decisions. Those kids will be treated with informed consent, and that's going to be gotten through other persons besides the patients in most cases. So critical to note, those interests do not go anywhere in contingency or crisis events. But the types of things that will dominate our brief discussion today include standard of care concerns, access, and liability. Next slide, please. I was there on that committee, the Crisis Standard of Care Committee, instituted by the Institute of Medicine. And during that committee work in 2009, we said and stated something that we stood behind affirmatively, that we're talking about in crisis when and how you're going to have a substantial change in usual healthcare operations and the level of care that's due to pervasive or catastrophic disaster. Now, we all know we learned that during COVID-19. We learned what an actual emergency looks like in the United States for a prolonged period of time. But the myth behind crisis standard of care, next slide, is that it's just about very substantial emergencies or things that a national government or your state government or local government declares as an emergency, and we've got to shift gears quickly. No, I really like how we've come back to terms through that committee, through the national academies now, and or through colleagues just like Maria and others. We understand CSC different. It's anytime sustained scarcities warrant real-time resource allocations to protect the public's health. It's when that balance you're seeing on screen gets skewed. When that happens, oh, you're shifting to crisis. You can be in conventional care today, and even in crisis later today, depending on what hits your pediatric hospital at what specific period, under what circumstances. It's a length and duration question, but to be sure, crisis is distinct from what we may have thought through originally on that committee. Next slide. Because the types of events and ways in which we may actually change the way in which legally we can respond to crisis events is very heavily dependent on what types of emergencies we may have declared, be it internationally, federally, through President Trump, or state and tribal emergencies through our governors, local emergencies through mayors and others. All of these have very significant impacts on the types of legal issues and concerns involving pediatric patients. So much so, as per the next slide, thank you, Damien, the types of issues that I like to call emergency legal triage is what you actually have to be prepared for. This is how you will mobilize legal and public health and medical authorities to make good decisions, prioritizing the core issues affecting those pediatric patients for that type of emergency in real time. Hey, doctors like Maria and Naomi are making tough medical triage decisions in these events all the time. Lawyers like me and others that work with ethicists and such like Naomi, we're making tough triage decisions on legal and ethical fronts too. That's happening in the background. But next slide gives us a glimpse into what about those issues pre or post emergency. What about those moments, as Kevin noted, when we're shifting into something, but we're not quite to crisis yet? We're in contingency mode. Crisis may be tomorrow, but today is contingency. What sort of tough decisions lie ahead? Next slide, Naomi gave us a very good sense of this. You're going to have, as you've seen, and all of us have experienced during COVID, but will experience again in your careers soon because of the types of issues we're seeing nationally, you're going to have some tough choices. They're going to be complex legal choices. They're going to come down to access and allocations. How are you going to allocate that ventilator? Who on this screen gets it if only 1 out of 12 does? Tough choices for sure. Note 2 of them are children. And where and how we prioritize that single ventilator, as Naomi was noting, could be used for any of these persons. Next slide. This is not good news. It's just news. We're not oblivious to this now. We have guidance that explicates legally exactly what you can and cannot do. And so let's be sure about some of the off-the-table untenable guidance, be it ethically or legally. For most cases, in almost every circumstance involving pediatric patients, you don't use these criteria to make those tough choices. You don't talk about ability to pay. It's not about ethnicity or race under any circumstances, honestly. Physical disability, pre-existing conditions, mental disability, take them off the table. Next slide. Also reveals something we learned during COVID. All of these factors are out too. The moment you're relying on these types of factors, you're seeing as core legal issues, from the most profound ones like ethnicity and sex and gender and age and other fronts. If you're using these as sole criteria for making tough, complex choices in contingency or in crisis around pediatric patients, you are on the border of unlawful decisions. And whether that trips the ethical norms or whether that's medically what might be justified, you're on that line. And if you're on that line, liability issues can arise. So what might we use? Take a look at the next slide with us. And that gives you a strong sense during COVID-19 what we started to learn. You base your complex decisions around specific resource limitations and suitability. What we absolutely know is the current medical or public health information, not guesswork, not what we think, what we know. Individualized patient assessments, not generalized assessments involving scores and formulas and things that may not be quite accurate for those patients. Really good objective medical evidence, equitable assessment scores that are demonstrated clinically to be equitable and not misused. Short-term survival rates, age when it is a prognostic factor. You can use it, we've seen legally. Other issues, patient and surrogate consent, healthcare worker status, the reciprocity issues we see legally can be justified. All of these may come into play and they may help you legally guide those decisions. Now, you may have ethical questions that arise and medical ones too, but legally this may help to some degree. Next slide. What about this question? What about who got vaccinated for an infectious disease that could have been prevented, perhaps through vaccination? What if the child on the left was unvaccinated, the child on the right was, and both of them desperately need that ventilator? Can you legally make that choice on which child was vaccinated? Oh, that's a tough call. If they were adults, it'd be a tough call. Some doctors still had to make it during COVID-19. But with kids, I say take it off the table. Those kids had no opportunity to fully affirm or deny vaccination. It's persons around them, their parents, caregivers, and doctors, and others that may have made some of those tough choices. Take it off the table. Next slide. Here's what you don't want to find yourself in: the web of liability risks. This is what lawyers look at. When we're looking at all the different liability risks that may arise in relation to delivering care, we're looking at all of these themes. And if you think we're just honed in on like one key theme, was there negligence involved? No, lawyers, we look at it all. Can we get you on any of these? Can we capture that healthcare worker who did something wrong within this web so as to capture you in real time? Next slide. We know where doctors do not want to end up. That's in the liability sinkhole. That's when you're going down the tubes because of something you did that lawyers have caught up with and tagged you, or at least are attempting to tag you with liability. How do you get out from under the liability sinkhole? Next slide gives us a nice example or illustration, and that is recognizing what's available to you as you make these tough, complex choices, be it in conventional care, quite honestly, as you shift to contingency care, as Kevin noted, and as you go full scale to crisis standard of care, you got two paths to follow here. Path one, just follow the evolving standard of care. It changes in these events. The standard changes. The law will accept standard changes in medical care depending on the circumstances. Good news. But a lot of doctors and nurses, they don't want to wait around for what juries determined could have been the standard. What you're really after is path two at the bottom there. Is there some sort of liability protection for healthcare workers and entities? And that next slide demonstrates something repeatedly that has come up during COVID and every other event involving pediatric and other patients. Can you find yourself under that actual umbrella of liability coverage? Is there something in that umbrella that applies to you, the healthcare worker, or any other decision maker, be it in hospitalist or otherwise, that will protect you from liability, insulate you, literally let you walk away from a liability claim? What I've found over repeated examples in multiple different environments, be it from Hurricane Katrina all the way up to COVID-19, more times than not, there are protections for medical workers and healthcare decision makers under that umbrella. But you've got to know where they are and find them closely. Next slide. It all gets risky. And it all sounds, quite honestly, scary if you're in this environment trying to make tough choices, especially involving pediatric patients, of which there are very distinct needs and clearly a recognition of what we can do as Marie was talking about, always providing care to the fullest degree we can, as Dr. Newton and others has noted. There's things you can do. First of all, recognize you're in a shifting standard of care at all times. The scope of practice can change and shift as well, allowing you to do things you might not have been able to do before an emergency event, or at least before a contingency. Transparency is so critical legally and ethically. Don't forget it. There's oversight and internal review processes that can help explicate these matters and help you avoid potential liability or access related questions. Soundness, so critical. Rely on it, utilize it, follow it, and the law will protect you. Consistency issues, can't even begin to emphasize how much that's critical here. And ethical adherence. It's not always the law will recognize a healthcare worker's adherence to ethical norms, but it's a strong guide, and one of which Naomi emphasized very well. In our final slide, I say thank you, and I'll turn it back over to Kevin to monitor some of our questions and comments. Kevin, back to you.
Great. Thanks so much, everyone. Really incredible presentations, really digging into this issue for which many of us have been working on for years, if not decades. As we enter into this QA session, we have a fair amount of time. Certainly encourage folks to use the QA box at the bottom of your screen. Looks like we do have one question in the hopper right now from Irene. Thanks, Irene. Operationally, you found that convincing C-suite and support departments like purchasing is easier. Operationally, have you found that convincing C-suite and other departments is easier when you have a plan in place? In Nevada, our statewide CSC used a multidisciplinary approach and has been used for justification of grant funding requests for planning, training, exercises, and supplies. Aligning CSC with EOP at the state has also been helpful. Would any of you, Marie, thoughts?
Of course, I thank you to my dear colleague Irene Navis, who does know the answer about two ventilators being used or one ventilator being used on two persons, since she helped to manage the Las Vegas shooting. One thing that I will say is I'm going to talk about at the state level and at the institutional level. So I chaired the scarce resource allocation group, having been commanded to do by the incident commander on day one of COVID in our institution. And that was an operational role. I am not an ethicist. I'm not a lawyer. I had ethicists on the committee, but the bulk of the committee was made up by people that understood supply chain, pharmacy, supplies, really good science about how we could manage things. And I would agree with Irene, if you can align these groups. And I reported to the command center 2 to 3 times a day. If I needed to convene the committee emergently for a new process or issue, I did. But we dealt with many, many, many things that came up. The complete depletion of renal replacement therapy in the hospital. We ran out of the ability to give dialysis, and without dialysis, some patients on a ventilator with renal failure would die. So we had to invent a graceful degradation, and I steal that phrase from Matt Wynia at University of Colorado, an ethicist. Graceful degradation of the standard, the gold standard, the platinum standard of renal replacement therapy was gracefully degraded down to some spreading the therapy, to leveling it out. So maybe you only got 12 hours of replacement therapy a day, but you didn't die of renal failure, and more people were able to be cared for. It was a constant reordering and revisioning and inventing. But if you don't have the construct in place to have people charged with that, I didn't know renal replacement therapy was going to become the thing. I didn't know I didn't know ECMO was going to be so much in demand. So we had to write an ECMO annex in real time that would allow us to manage ECMO ethically. And but the mechanism by which one convenes, discusses, votes, accesses the right information, does it ethically and with counsel at your side, having that in place strengthened us as an institution. And those same principles were drawn from, and it was sort of a bidirectional because I sat on the state committee, having the state methodology in place allows us to do a better job at our healthcare resource coalition level too, and allowed us as a state to convene when we got a tranche of remdesivir, for example, or the drug that was in scarce supply at the beginning, or a tranche of immunoglobulin. We could put it in the right place in the state. So if you don't have a way in place to call people up to make these decisions and have responsible roles, it's not the people. I won't be here forever. The role that does strengthen your ability to get your, and not necessarily with grant money but to actually put the resources to conveying the needful item to where it is most needed. So I'm going to say duty to plan. If you have a construct of some kind to do crisis standards and scarce resource allocation ahead of time, and I would even argue that you should exercise it with perhaps a scenario of scarcity, because when you do have to really do it, it's easier to do. It's can be done responsibly. I don't know if that completely answered Irene's question, but that was my experience.
Excellent. Thank you. I do see a couple of open questions. James, it looks like you're typing into the one. Given that laws are so different state to state, how do we know as individual states what's out there if you're not intensely involved in this work?
Yeah, Kevin, good point. I saw that question too. I was going to ask the questioner what state that person comes from. Let me give you the answer though, without even knowing it. The answer is you bet there's good analysis out there state per state. And mind you, you're going to have to sometimes look for it in different places. If it's related to states that I've worked closely with, like through RAPM and Region 1 and some of the other jurisdictions, we've done very systematic reviews of state-based laws and policies. I'm based in Arizona. We've got an unbelievably strong sort of approach to how you think through these crisis issues in Arizona. The standard we see there is just gold standard stuff. And then many of my great colleagues working in emergency legal preparedness, like my great colleague Lance Gable at University or at Wayne State University, and so many others, have systematically documented state and even local laws on emergency preparedness issues. Depending on what state you're in, we can certainly pinpoint where some of the best analysis is related to that.
Great, thanks. Let's go on to the question from Don and the comments. Don Bailey, having the chance to work in Arizona with Professor Hodge on CSC, there's an opportunity to ensure plans include consideration for those with special healthcare needs and other disabilities. Not every hospital or provider may see it the same way, although many of us do. Naomi, maybe a chance to jump in on that question if you're in a position to respond about inclusion of children and youth with special healthcare needs and disabilities?
Yeah, I mean, this is, I think, this was the question, I think, for pediatrics. I think the different people approach questions like this in a different way. For me, it's always been start with epidemiology and start with knowing, do you actually understand the populations well enough? Because a lot of times, you know, that lack of understanding, there's bias, but there's also just not having current facts. And if you can sit down with people and talk about, like, do you actually understand what contemporary outcomes for these children are? That's a really important place to start and get everybody in the same place and talking about what these outcomes are, and then engage in perspective taking around what it's like to be that parent, to be told your child isn't worth it because their quality of life is different than what you think of a healthy, sort of a healthy, typical child being. So, you know, I think that thinking about that, thinking about it explicitly, was really important, bringing in contemporary information. And also, again, just like bringing in multiple perspective takers. So like one of the most helpful things for me that happened was I was approached by a child neurologist who said, I am worried about children with neuromuscular disorders. Can you help me write about this? And I didn't know a lot about that population. It's not who I take care of, but I know how to sort of like apply ethical analysis to a question, right? And so those kinds of collaborations, being able to go to an expert in those conditions, listen to what he had to say to me about those conditions, and say, here's how I would apply, you know, like ethical principles to that consideration. I don't know if that answers the question, but to me, you take the approach, this is not something that you're not an ethicist or you can't understand. You say, let's try to understand this together.
Excellent, thank you. I'll hold space for any other last minute questions. If none, then we'll transition to the next step.
I did want to comment that as a person who is not trained as an ethicist, I saw and who's old and has been here through the writing of these guidances, first at the state level, in the late aughts when we were worried about avian flu, and saw that guidance be revised. The thought about judging somebody else's quality of life, with like withholding care that could be reallocated because somebody has a perceived different quality of life than you, was palpably different in the 2020 revisioning of our, or reimagining of our crisis standards, to build on what Naomi said. The ability to really look at advances that we've made and to understand that everybody did not feel that because your quality of life years or some number may not be as long as somebody who has no medical conditions, that there should be, you know, a diminution of your worth to be eligible for a life-saving care. However, what we did do that I thought was really important, and I want to build on James's concept of consistency, we followed our own policies. If you ever do med mal work, if you don't follow your own policy in a hospital, how fraught that is. And one of the really good moral policies that we have at my institution is we allow our attending physicians who are skilled to not give non-beneficial care. In other words, when it is clear that somebody's being harmed or in pain or is not benefiting from continued flogging and non-beneficial care, we have a policy around how the clinician should approach that. That was just absolutely key at the beginning of COVID, to make sure our clinicians knew what was their duty according to our policies, and it comported well with the ethics and the legal underpinnings of managing. And it had nothing to do with COVID. It had to do with, if you are allowing resources to be spent on non-beneficial care, which was just clearly causing a lot of moral injury to the providers and to the family, and harm and pain to the patient, you were morally and legally obligated to approach and discontinue that non-beneficial care. So consistency about those policies that had nothing to do with the crisis standards of care were really important for my institution.
Yeah,
Great.
that's so
James,
true.
something to that?
Yeah, I would just add one quick note, Marie, that's so well stated. It's so critical. Lawyers that take a critical eye to these look for the first thing, or one of the first things that we look for is, so you treated this patient differently than this one? Explain why. And if you can't do that, even during the throes of an emergency, you're in the legal trappings of that web I was talking about. But when you can demonstrate it was our consistent policy and approach to applying what was known to be the standard of care at that point in time, the law is designed around doctors escaping liability under those circumstances. It's not a liability event. Patients can have bad outcomes, unfortunately, but it's not a liability event.
Great, thanks. I see one more question. This will wrap us up for the Q&A. Who'd like to take this question from Jeremy? How does this group see changes in potential funding changes in preparedness planning impacting the future work on
Oh, well, I'll
crisis?
take a 30-second crack at it because I'll start with a very brief observation. It's going to be very detrimental. This funding has been so critical to how we actually accomplish some of this planning nationally and across the states. But on the flip side, we've been at this for years. States know now what their responsibilities have been on CSC planning, and those that have done it well can perpetuate some of that even without some of the funding. It's going to be necessary for states to pick up that mantle and actually run with it. I'll defer to Naomi and Marie for additional observations.
Well, I would really like to highlight the fact that Kevin did this in the state of Utah and like to hear his perspective. Kevin, how would you do this at the state level with this funding stream issues that we have?
Although we don't know the final outcome of how funds might be impacted, we do, as emergency managers, prepare for the worst. Listen, a lot of this work is aggregating the best of the best within a state to have discussions. It may not be as may not need the level of funding such as things equipping, hosting major exercises. So I guess what we have to figure out is what is the motivation of the hospital systems that operate within a jurisdiction to allow people to join a work group, to contribute to plan updates and other items like that. Beyond that, yeah, having run HPP and FAP and other programs for a number of years, something like this may be prioritized out if states experience 25, 30, 50% cuts. James, you're thinking?
I'm thinking I think you're right about that, Kevin. It's a very big concern. It's not just about the preparedness funding that's may be withdrawn. It's the Medicaid population we may lose soon. It's the changes in Medicare policy that are funding so much of what we do. Let's save that for another webinar in the near future because we're all really kind of taking it all in and absorbing it, but changes are afoot. It does not change, I think, for any of our purposes, our responsibility to give the best quality care we can to the most number of patients in emergencies when they need it best. So I don't think that mantra ever changes.
Yeah, and Marie said it outright, that duty to plan does not go away regardless of the situation. Damien, if you could bring up the closing slides just so we get everyone going in time. For those that have hung on, and thank you all so much, both to the speakers and to our attendees. If you've hung on and you're interested in continuing education, this information will be sent to you shortly as a registered attendee. But as you can see, the attendance code of YAQHAL is available here at the end. That is going to validate your participation throughout this. Damien, can I turn to you for a moment? Did I miss anything else with either CE or anything on this webinar?
No, Kevin, we've covered everything. Just for the group, you will receive an email by close of business today with all the same information in order to access continuing education credit. Thank you.
Great. Well, thanks again. As we said, as we do with many of these things, and as Marie noted, we'll be posting this up on our webpage for continued access to it. We thank you all and we'll cut you loose for the day. Thanks everyone for joining us.